Hello, everybody. Good evening. I'm Dr. Ratna Puri from Gangaram Hospital in New Delhi. It's a pleasure to be able to be with you today through this webinar. It's a little unnatural experience for me because I'm not being able to see you all, what I'm used to, but I think it's a tremendous way to disseminate information, knowledge, and experience. And I, at the outset, would really like to first thank the Society of Fetal Medicine and especially Dr. Ratna for taking things forward in such a brilliant way. So today what I'm going to talk to you is about just a bird's eye view of the application of genetics within the ambit of obstetric care and fetal medicine. And at the end of the talk, from now on, you're just going to be able to see the slides. But at the end of the talk, we would have a discussion and I would be able to answer any queries or any doubts that are raised during the course of the slide presentation. So we just wait for the slides to come on. So the title today is Genetics in the Clinic, an update for the obstetricians. So I think gone are the days when we used to talk about genetics being just a laboratory science or about gene therapy. There has been a tremendous transfer of the technology from the bench to the bedside, and it's related to diagnosis, prevention, and treatment. And therefore, it is very, very important to keep abreast, to be able to be aware of what's happening, because that is the key to application in the clinic. So what are the indications of a genetic evaluation in obstetric practice? Advanced parental age, both that of the mother as well as the father. If there is a previous child with dysmorphism, autism, malformations, intellectual disability, deafness, albinism, thalassemia, short stature of genetic origin, neuromuscular disorders, cerebral palsy, metabolic disorders, or hemophilia. And this is just to name a few. It could be, the previous child of that parent, of that couple, or there could be a family history of these. The presence of consanguinity, unexplained stillbirth and neonatal deaths. During pregnancy, if during screening there's a high aneuploidy risk or an ultrasound abnormality or a teratogen exposure, intrauterine infection. In women with primary amenorrhea or recurrent pregnancy loss, or if there is a history of premature ovarian failure in that family. So we really start with something which is very basic and common to what we learned in MBBS, and that was the presence of family history. Okay, so that very, very relevant to genetics is the presence of consanguinity. We know that in some parts of our country, this is as high as 15 to 30%. But if there is a history of a genetic disorder, now this could be a history of familial breast cancer, or if we even take some specific disorders which have specific modes of inheritance. And I would take you through some of these. You have the typical autosomal dominant pattern of inheritance in conditions like tuberous sclerosis, neurofibromatosis, or Huntington chorea. Autosomal recessive disorders like thalassemia, spinal muscular atrophy, deafness, and the common X-linked disorders of hemophilia A or B and Duchenne muscular dystrophy. So how does taking a family history help us in the clinic? Let us see this example, because just based on the pedigree, even without knowing what the disease is, we can discuss the risks of recurrence. Now here you can see that there are multiple members within this family who are affected in a vertical pattern, and thereby we know that it's coming down generations. So this is a typical autosomal dominant pattern of inheritance where multiple generations are affected. And because the father of this fetus is affected, there is a 50% chance that this baby would have the disease that is present in other members of the family. So let us take this example. This is a couple who have come for prenatal testing in view of this family history. This family history is of a neurodegenerative disorder called Huntington chorea. And though it is of late onset, but typically it takes away the ability of the affected individuals to walk, and there are tremors and cerebellar involvement. Now, this gentleman at 28 years of age, I've told you this is a late onset disorder, does not know whether he has the disease gene or not. And he really doesn't want to know either because there is no treatment for this. And this is a common scenario we face. But we know that his mother has Huntington chorea, and this has been confirmed molecularly. There is a 50% chance that he has inherited this abnormal gene from his mother, and a 50% chance that he has not. But because he does not want testing, they request that the fetus may be tested directly to know whether this gene that is not functioning in the grandmother is there in this fetus or not. And this is possible as long as we have confirmed it in the lady here. So this is a common scenario. Now, if the fetus is affected indirectly, well, they know that he is affected. But if the fetus is not affected, he still does not know his affection status, and which is what we want. So let's take a second scenario where this lady is planning pregnancy. It's before conception, and she tells us that she has a brother who could not walk, and as always, the reason is polio. So when we take it forward and ask for a family history, see what we get. So this was the original lady who came for consultation, and this was the one brother who was supposed to be having polio. But here you can appreciate that he has a maternal uncle also who had a similar disorder, as well as their sister had a prenatal diagnosis done for a similar disorder, and the pregnancy was discontinued. And they didn't know, and this is very common in families where there are genetic disorders. So by taking all these details, we ascertained that this disease was Duchenne muscular dystrophy, which is an X-linked recessive disorder. And this red chromosome is the one which is causing the disease phenotype. And because her offspring had it, she is a carrier. But we don't know whether this lady has inherited the normal chromosome from the mother, that is the black, or the one with the disease gene, that is the red. So there is a 50% chance that she's a carrier and a 50% chance that she's not a carrier. And this is the test that has to be done. If she's not a carrier, there is no risk of DMD for the fetus. But if she is a carrier, then the test would need to be done. So therefore, in such situations, it is very important to ascertain the carrier status of the at-risk individual in the pedigree, like this lady, by the molecular method. Now remember that when we talk about genetic disorders and recurrence risk, it is a risk in each conception. Let me take this common example, and this example is that okay. Now this example is this family who is pregnant. She knows that 2 children died in the neonatal period, and they were diagnosed to have an autosomal recessive disorder, which is extremely common in India, called spinal muscular atrophy. And this is a neuromuscular disorder where in the severe phenotype, the child really doesn't survive beyond the first or the second birthday. Now, this was confirmed in the 2 children. Both the parents are carriers, and that's the red line that you see here. The disease phenotype will only happen if both the reds come together. So in every pregnancy, there is a 25% chance that the 2 reds will come together to cause the disease phenotype, but a 75% chance that the baby would not be affected. And remember, this is for each conception. This pregnancy did not have any memory of what happened, and this pregnancy has no memory of what happened here or here. And therefore, it is incorrect if we say to the family that Here, the baby in the third pregnancy will be normal because an affected will not be born each time and the baby will be normal. Unfortunately for this couple, they did not do a prenatal diagnosis because they were not counseled appropriately, and they ended up in having a third affected baby with spinal muscular atrophy. Now, another scenario that we are commonly noting now is that patients with disability marry. Now, this is a bit of a complicated situation because here we have to ascertain the risk of both diseases for the fetus. And let me give you one example. This was a husband who had short stature and contractures of the hands and the spine since 5 years of age, and no definite diagnosis had been made. His wife had a history of difficulty in walking, jumping, wearing slippers. Her muscle bulk had become very thin, and she had a nerve conduction study which showed that she had some sort of a neuropathic disorder. So first we had to start with the husband. We made a clinical diagnosis of a skeletal dysplasia called pseudo-rheumatoid progressive chondrodysplasia. And we know that this is caused by a common mutation in India within this gene, and we tested him for that mutation. Once the diagnosis was confirmed in him, and because it is an autosomal recessive disorder, we had to then check his wife to see whether she had that disease phenotype or no. And because we identified that she was not a carrier for this disease, there was no risk for their baby. So we did not have to test for this disorder in the fetus. However, when we confirmed that his wife had an autosomal dominant kind of a neuropathy because of a mutation in this gene, which is called the MFN2 gene, we know that this is an autosomal dominant disorder. The risk of recurrence for that fetus is 50%, and a prenatal diagnosis had to be done to ascertain whether this specific gene change had been inherited by the fetus or not. So in addition to counseling for the risk of recurrence, remember, as you have seen in the previous cases, we have to determine the genetic basis of the disorder in the family before conception. Now, this is ideal, but how many of them actually come in the preconception period? We know that it is a rarity, but otherwise, what is very important is that in the very first visit, we should ascertain the risks, take family histories, see if there is a risk of recurrence, and do the genetic testing accordingly. Okay, so while we are just waiting for some of the slides to come back, because I think there is a bit of a problem with the broadcast, essentially now we have concluded that the family history, which is just sitting with the family for 5 minutes during their first visit, is so very important. Because remember that if there is a genetic disorder and we have to do all these tests, genetic tests take time. The reporting is about 2 to 3 weeks before we can even ascertain what the disease is, what is the risk for the fetus, what is the familial mutation. And pregnancy does not wait, it keeps carrying forward. And therefore, if we cross that 20 weeks time limit, it's really a challenge for us. After this, then we come on to, I think we just move forward. Is there a challenge with the slides? Okay. Okay, so I'm just going to move forward. We finished with all this. So this is where we are. So remember that in the first visit, we need to do all this because reporting of genetic tests take time and pregnancy is not good. So along with the family history, what we do in the preconception period or the first visit is carrier screening. And as you all know, and we've talked about repeatedly over and over again, we need to do mandatory thalassemia and hemoglobinopathy carrier screening in every lady. We are not to wait for the birth of the first affected child. The carrier status in India varies from 3 to 13 to 15%, and it's very high. Because a hemoglobin is done for every pregnant lady, it is important to combine it with the MCV and MCH and the RBC count. because a high RBC count for a specific hemoglobin level, an MCV less than 80 femtoliter, and MCH less than 27 gives you a clue that you could be dealing with beta thalassemia. We do not want to wait to keep giving a trial of iron and getting the hemoglobin to rise before we start testing. In addition to that, we can do an HPLC for hemoglobin A2 and F levels. You do it in the lady. If she is a carrier, please screen the husband. The risk for the fetus is again only if both partners are carriers. And if both partners are carriers and a prenatal diagnosis has to be done, as for all other disorders, we need to do the HPV gene testing or the thalassemia gene testing in the couple, identify the mutation, because that is what we are going to check in the fetus. We cannot do the HPLC in the fetus. And also remember that when you are counseling a carrier couple, it is also imperative to tell them that their siblings and cousins need to be treated because they are also at risk of being, need to be tested because they are also at risk of being carriers. I've just put up this slide because this is something you need to have in your clinics. What are the situations where a prenatal diagnosis is required? Because we also see that if in the lower part of the slide, there are many situations where prenatal diagnosis of beta thalassemia is not indicated. And one example is the very common variant of hemoglobin B Punjab or DRN along with a beta thalassemia carrier. In addition to thalassemia, I've already talked about spinal muscular atrophy. The carrier status is about 1 in 50, so you can imagine the probability that two carriers get married is fairly high. But remember that the carrier test for SMA is not the same as that we do in a child who is affected. It has to be a quantitative test, so be careful where you send your samples off for an SMA carrier screen. We also do fragile X carrier screening. One, if there is a family history of an X-linked intellectual disability, or the lady has premature ovarian failure because she is at risk of being a fragile X carrier. Now, there are a large number of expanded carrier screening panels, but remember, before sending these off, appropriate genetic counseling for the couple is very, very important because they can return with some results which we don't know how to handle. And this was an interesting paper which came out a couple of years ago, which really talks about how it is important to keep abreast in obstetric practice with genetic counseling and the changes that are coming, so that as we know that the obstetricians play a very important role for their patients. When we talk about the role of genetics in infertility, we know that male factor infertility, especially where there is oligospermia and azoospermia, has a fairly high genetic contribution. Therefore, it needs to be tested, and I don't see this very often in clinical practice. They go in for IVF without really ascertaining what the cause of infertility could be. You need to look for chromosomal disorders, Y microdeletions, and the congenital bilateral absence of the vas deferens, especially if there is azoospermia and oligospermia, which is obstructive in nature. We know that if there is a female factor infertility, especially if it's associated with premature ovarian failure, there are a host of genes which can cause this phenotype. So that is related to the etiology. But when we talk about the infertility and the risk of genetic disorders, the couples need to be counseled that there is a slight increase in the risk beyond the baseline risk in natural conceptions. And secondly, the impact of the specific ART procedure on the epigenetics and the various kinds of disorders like Russell Silver and Wiedemann Beckwith is not well known, and much more data is now unfolding related to the consequences for the offspring. Now, moving to something which I think everybody is familiar with because a lot of talks have already happened on this, is screening for Down syndrome in pregnancy. You can see in this slide that there has been an evolution from the 70s to the 2011, where we are now in the era of screening with biochemical markers along with ultrasound markers and now cell-free fetal DNA analysis. So this is just a little snapshot If the woman comes to you in the second trimester, after 15 weeks of gestation, please do the quadruple test because the triple test, the sensitivity is very low. The advantage of this is it also looks at the AFP, which can give you a clue for pleural tube defects. And if it's high, you would follow that pregnancy up very carefully, do a targeted ultrasound with it in mind that you have to look at the spine as well as follow the growth of the baby. But however, when they come to you in the first trimester, it is good to do the first trimester screen because it's got a high detection rate. Cell-free fetal DNA has really taken over the world with a storm, and especially India. But remember, it is done after 10 weeks of gestation, and the way to do it is the nuchal translucency scan if that is normal, and the risk is high in a contingent manner because that is something which is a little more cost effective. So we have tried to put forward some suggested guidelines and the available screening options for India in a paper in the Indian Journal of Medical Research. And it was published in December 2017. And you can go and have a look at this paper for pregnancy, for women who come in the first trimester, second trimester, and how you could use the cell-free fetal DNA analysis. Of course, everything depends upon the local expertise and the availability as to where you are practicing. Now, coming to the spectrum of genetic tests that are available, we know that really there are three categories of disorders, and if we keep that in mind, it's very easy to understand the tests. We have the chromosomal disorders, we have the single gene disorders, which occur because of a mutation in the gene. For the former, we look at the chromosomes. For the second, we do the DNA-based tests to identify the specific gene change that has caused the disorder. And then you have an example of the single gene disorders is thalassemia, SMA, hemophilia. And the third group are the multifactorial disorders like neural tube defects, which are not only associated with a gene change, but have a lot of environmental influence on the development of the disease field. So taking the group of chromosomal disorders, what are the indications of testing for these in obstetric practice? Recurrent pregnancy loss, infertility, antenatally detected anomalies, a previous child with a chromosomal disorder, if one of the partners is a balanced translocation carrier, and of course in primary amenorrhea because we want to look for Turner syndrome. So what are the various types and how do you choose the best test for chromosomal disorders? So we know that there are 4 kinds of tests to look at the chromosomes. The first is this karyotype, which looks at the 23 pairs of chromosomes. And because we know that these 5 chromosomes are the commonest ones which are associated either with antenatally detected anomalies or with an abnormal screen, we have various technologies like the FISH and the QF-PCR, which can one, look at these 5 chromosomes. In addition, the FISH test, which is the fluorescent in situ hybridization, looks at very specific targeted areas on the chromosome. So if you have a fetus with a cardiac defect and you want to look for the 22q microdeletion, you will do the FISH test to look at only this 22q microdeletion and you don't know what's happening elsewhere. Okay? So therefore, for this you need to know what you're looking for. The third kind of test that has come up is the chromosomal microarray, which looks at all the 23 pairs at a submicroscopic level to look for gains and losses throughout the human genome. So this is the biggest advantage of this chromosomal microarray. And I'm just going to take you through some examples to understand how to choose them. This is third trimester, polyhydramnios, the double bubble, possibly duodenal atresia. You know that 30% of these could be because of Down syndrome. Otherwise, it's just a major malformation which needs surgery after birth. So in this situation, you can do just a FISH test to look for Down syndrome. If you see 3 probes like this, you know that it is trisomy 21. Or you could do another DNA-based technology, which is the QF-PCR, to look for 3 peaks that is associated with Down syndrome. So this is another case scenario. This is a lady who is 38 years old. She had 1 child with intellectual disability and then by chance conceived after many years of life, which is not unusual. Now, essentially, she was only worried about the risk of Down syndrome because it has created such a furor in our practice because of her age. And she completely forgot as to the fact that why does she have a child with intellectual disability? So the test, the fish came back as normal because we were testing only chromosome 13, 18, 21 and the sex chromosomes. But when we did the chromosomal culture to look at all the 23 pairs of chromosomes in the karyotype, we found an abnormality in the fetus, which was an extra chromosome, a little extra part on this chromosome 3. And you can see that they are different, otherwise the chromosomes look identical. And then went and did the child and found the same problem in the child. And obviously, this fetus was also affected like this child, and one of the parents could be a translocation carrier. And this is something that was only picked up in the karyotype because the fish was not targeted towards this because there was no prior knowledge that this could be the disorder. Now, how do we use a microarray? Now, a microarray picks up everything of a karyotype and a fish that is going to cause a disease phenotype. An example is here. This was a lady where a CVS was done for a nuchal translucency that was 5 millimeters. Now, typically we think that it's only one of those 5 chromosomes, but the fish study which tests the 5 chromosomes came back as normal. And what the microarray picked up was an abnormality in chromosome 7. And if you see this one line, this little line on chromosome 7 was duplicated. In the microarray, it is magnified to this extent, which is why we pick up the duplication. Within this duplication were genes which were going to cause intellectual disability and cardiac anomalies. And here, because of the microarray, we understood that the phenotype of the baby is going to be affected with these specific disorders. Whereas if we had just done a karyotype of a fish, they would have come back as normal. So some important points to note about the microarray is that it will identify all abnormalities that are detected by a karyotype and may identify additional abnormalities of the chromosomes. But at the same time, it will not identify all genetic disorders because we still have the group of single gene disorders. So what is the diagnostic value of a microarray after a normal karyotype? If you have an ultrasound abnormality in the fetus, it picks up an additional 6 to 13% of abnormality. And even if there are no ultrasound abnormalities and you've done a microarray, you've done an invasive procedure for various indications like say a positive triple test or a first trimester screen or an advanced maternal age, it picks up an additional 1 to 2% abnormality. So there are various recommendations. This is the ACOG guidelines published in May 2016 that recommend that microarray analysis should be made available to any person who's undergoing invasive testing. It is better than a karyotype if an invasive test is being done, especially in the setting of a fetal structural abnormality. And of course, we all know that an amniocentesis before 16 weeks of pregnancy is not recommended. But what is really important and the message we need to take back, just testing for the chromosome 21 alone is not enough. But remember, in our setting, everything is an out-of-pocket expenditure, so there is nothing mandatory. We have to discuss with the patient and see what is the important thing that needs to be done and can be done by that family. Now we come to the other group of disorders, which are the monogenic disorders or the disorders that occur because of mutations in single genes. Now I'll give you this as an example. This was a child who came into the OPD and the lady was pregnant. Actually, at that point in time, she should not have been colored because she was normal. And she had gone to college and she was now looking after her child who had severe intellectual disability. So she was sent for a CVS for intellectual disability. Now, there is nothing like that. We have to ascertain the cause of the intellectual disability. So when we examined the child, we saw this cutaneous phenotype as well as the MRI phenotype, which suggested a diagnosis of tuberous sclerosis. And then we saw the mother. So though she was intellectually normal, she had a lot of stigma on the face, which suggested that she too had tuberous sclerosis. So you can see that she had these little angiofibromas, she had this nail dystrophy, as well as these dental pits, which typically tell us that she also had tuberous sclerosis, and this is an autosomal dominant disorder. So what was the challenge? She had tuberous sclerosis. Her first child had tuberous sclerosis. And because it's a dominant disorder, there is a 50% risk of recurrence in the current pregnancy. How are we going to check the fetal status? So first, we would need to check the change in the gene in the mother or the child. Once we identify the mutation, only then can a CDS be done to check for that one mutation identified in the affected child. Remember, the CDS is a very precious material and we cannot play around with it. So we need to know exactly what we are checking for. Tuberous sclerosis has two genes which can cause the disease phenotype. We know from our prior knowledge that the TSC2 gene is the most common gene. So we took the DNA, or we took the blood of the baby gene by saying, identified the change in the gene. And then we did a prenatal diagnosis to check for the presence of this one mutation in the fetus. And we identified that the fetus was also at risk for the same disorder in this current pregnancy. So therefore, whenever we have a family history of mental retardation or any suspected disorder, in any genetic disorder, if it's a single case, it could be genetic or non-genetic. So you have to start from there. Take the history, examine the affected child, make a clinical diagnosis. Then we have to confirm the diagnosis by the appropriate genetic test. If on examination we feel it's a chromosomal disorder, we would do the chromosomal tests. If we feel it's a single gene disorder, then we do that specific test. Then we reascertain what is the risk in the fetus for the specific disorder, and only after that is CDS and prenatal testing possible. When should the prenatal diagnostic testing be offered? In addition to a positive screen, we now understand, after all seeing these cases, that there are many indications of doing invasive testing beyond just a positive Down syndrome screen. These are some of them. If one of the parents is a carrier of a chromosomal translocation, we know that there is up to a 30% risk that the fetus can have an unbalanced translocation and have intellectual disability, so we need to test the fetus. If there is some parental aneuploidy, say if one of the parents has Klinefelter syndrome, or you could have a Turner syndrome mosaic who could become pregnant. If there is a prior child with a structural birth defect, or if there is some genetic disorder in the family like thalassemia, neurofibromatosis, hemophilia. The previous child or a fetus had some sort of a chromosomal abnormality, an autosomal or a sex aneuploidy, or if there is a fetal structural abnormality. These are all the indications for doing a prenatal diagnosis. What laboratory test on the fetal sample obviously depends upon the indication for the test. If it's a chromosomal disorder, based on what you want to look at, you would either do a FISH or a QF-PCR to look at specific points on the chromosome. You could do a karyotype, which has which has less resolution compared to a microarray, which would give you additional information beyond the karyotype. Remember, the indication is important, as is the cost and what the family can afford. We would look for the genes and test for the specific mutation for disorders that are the single gene or the monogenic disorder. And an example of what kind of a laboratory test, say if you have a fetal malformation like omphalocele, we would look at the chromosomes because 30 to 40% have chromosomal abnormalities. And say if the omphalocele is associated with hepatomegaly or a large predate baby, you would suspect Wiedemann-Beckwith syndrome. Now, this is not a chromosomal disorder. So if the fetus has Wiedemann-Beckwith and you check the chromosomes, they will come back as normal. You need to think of Wiedemann-Beckwith syndrome and test for that specific genetic disorder. And we know that for increased nuchal translucency, as an example, We typically like to do a chromosomal microarray and may or may not do the panel of genes for the rasopathies, Noonan syndrome. What is the best sample for prenatal testing? Early in gestation, chorionic villi. If you want to do single gene disorders for DNA testing, chorionic villi are better because it gives you better quality and amount of DNA. If you want to look at the chromosomes, you can use either amniotic fluid or a CDS sample. And the advantages of fetal cord testing is that in addition to doing all the tests that you can do on a CV or an amniotic fluid, you can also look at, say, the hematological profile of the baby, especially if there's a non-immune hydrops. You could do enzyme analysis in these fetuses. But it is very important for all of us to know that whenever we do any prenatal test, we need to check for maternal contamination to differentiate fetal and maternal tissue. This is done by two methods. One, by dissecting the villi, as you can see here. These are the chorionic villi with no maternal decidua. And second, by the molecular methods. Now, just before I conclude, I want to bring some things to light. Now, the first family, if you see, had two children who died with a metabolic disorder called citrullinemia, and they died in the in early infancy. This third child had been admitted in a tertiary care hospital, and there was a summary with the family which said that this child had citrullinemia. However, at 18 weeks, an amniocentesis was done because of a positive quadruple test, and all that was looked at were the chromosomes, which came back as normal. It was only much later, at about 26 weeks of gestation, that it dawned on somebody that this was nothing related to the chromosomes, that this was a single gene disorder. And that was a higher risk for this fetus, a 25% risk for the fetus compared to the risk of a chromosomal disorder. And if you take the second family, the first child was operated for anal stenosis but was fine. The second child had sensory neural hearing loss. The pregnancy had been carefully followed up since the first trimester. Various dual marker, triple marker, torch test, repeat torch test, everything was done. And it was only at about 18 weeks that the family was referred for prenatal diagnosis in view of this child being affected with hearing loss. There are 40 genes that can cause deafness in an affected individual. And there was really limited time to start testing all the 40 genes in this affected individual to then offer prenatal diagnosis. So essentially, these are just little eye openers for us to have a wider perspective, because these are situations we need to avoid. We need to look at the couple, the whole picture at large, and understand that all fetal diagnosis is not related just to antenatal scans or Down syndrome screening. And just before I conclude, I think because I'm talking to a large number of obstetricians, we don't have a mandatory universal newborn screening program in our country. And I think we are doing such high-end level medical management of patients in all spheres and in all specialties. But I think it is a personal responsibility of each one of us that we need to bring in at least newborn screening for hypothyroidism, because that is something that is treatable at very, very little cost. And you could have an absolutely normal baby if treatment is started in the neonatal period. So possibly, if as individual doctors we insist on it, it will dawn on the government that this is something that needs to be done. It is happening in many states, but we need to ensure that every child who's born is screened for newborn screening. And once that is in place, we could add on other disorders like congenital adrenal hyperplasia, galactosemia, G6PD deficiency, biotinidase deficiency. All these conditions are where the children benefit a lot by instituting early treatment. So what are the take-home messages? We need to have a holistic approach to pregnancy. We need to think beyond Down syndrome. Never forget thalassemia. Remember that one jacket does not fit all. Every case is an individual case. Choose the test appropriately. Refer early if a genetic disorder is suspected. Prenatal testing needs identification of the genetic mutation before a CDS or an amniocentesis is done. And remember, no matter where we send the test, we need to be aware of the quality control of all the tests that are performed, be it a scan, be it a screen, or be it a diagnostic genetic test. Thank you very much. And this is my department to whom I'm really deeply indebted because everything I've learned comes from here and from my training in Lucknow. Thank you. So that really concludes my talk, and I would be happy to take any questions if there are. And especially possibly in some areas which are not covered, some cases that have come within your clinical practice where maybe I could help to answer questions. I think there is a way for the questions to come onto the screen, and that is what we are waiting for. So there is one question which says that an increased NT, do you recommend microarray to all? So an increased nuchal translucency is like an anomaly we see on the scan. So a microarray can pick up an additional 5 to 10% abnormality beyond a karyotype. So we do recommend it, but like I said, for all these tests, because they are high-end expensive tests, we don't force it. It depends upon the family. You have to guide them what is the difference between a karyotype and a microarray. And what is also very important is that every microarray report that comes back and reads that there is some sort of a change does not necessarily mean that there is an abnormality. You need to go into the details of that report to see are there any relevant genes, is it a known microdeletion duplication syndrome. So as we are using more and more of the technology, we need to understand a little bit about the reports as well. There is another question that says, in prenatal, do you suggest CNA and in POC for karyotype? Okay. So for the products of conception, when we do a karyotype, we know that the success of a karyotype is only about 50% because a karyotype needs, live cells. So every time you may not get live cells. So that is why either we can do a low density microarray because that's cheaper, or also sometimes laboratories can give you subtelomeric MLPA because that most of the abnormalities that we have identified using chromosomal microarray are subtelomeric. Okay, but yes, it is definitely better than doing a FISH test. You can combine it with a FISH test because if it's trisomy 21, then you don't need to go ahead with the microarray. But a karyotype, usually a microarray is better than a karyotype. What is QFPCR? A QFPCR is a quantitative fluorescent polymerase chain reaction. It is a DNA-based test. It is like a FISH test. Typically, we use it, say, if you've done a prenatal diagnosis for beta thalassemia, the fetus is not affected, and there you want to check for chromosome 13, 18, 21 and sex chromosomal aneuploidies. In the same DNA that is in the lab, you can do a QFPCR. It's another technique which checks for the 5 chromosomes. For amnio, do you recommend? I don't understand this question. For amnio, do you recommend after PCR or FISH? Oh, QF PCR. Both are okay. So if you're doing, say, a microarray, we could do a QF-PCR on a microarray because it's both using DNA. Okay? If you're doing a karyotype, you can do fish or karyotype. Remember that the QF-PCR and the fish give you the same information because if you're doing it for looking at aneuploidies due to abnormalities in chromosome 13, 18, 21, and the sex chromosomes. The next is the mother beta thal minor, husband delta beta thalassemia. That means the husband is affected. What should we discuss in preconception? So delta beta thalassemia and beta thalassemia, there is a risk of thalassemia for the fetus, and you could discuss with them in the preconception period. Now here, because the husband has delta beta thalassemia, that means he's got either thalassemia major or thalassemia intermediate, depending upon the phenotype. So there is a risk of disease for the baby. So if they want a prenatal diagnosis, you would do the mutation testing and test for the fetus. Remember, in a prenatal test, you could never tell them whether the fetus has major or intermediate. So intermediate is a milder form where it's only at times of stress they develop low heat blood transfusion. So the phenotype, you could never tell in prenatal life. So that's a call they would need to take. Do you recommend QFP? I think that QF-PCR for the 5 chromosomes answers the same questions. So it depends what is the expertise of the lab test. What is a genetic sensory neural hearing? That's interesting. I've recently seen 2 children in the same family, 2 siblings with unilateral sensory neural hearing loss. So Beck Association and the connexin 26 gene, which is the commonest gene that causes deafness, can have missed this disease phenotype. Case with hearing impairment in previous child, what screening to be done in the current pregnancy? So if you have one child with hearing impairment, and that is prelingual, that means there was delay in this development of the speech, so obviously it is more likely to be congenital. Remember, hearing loss can be genetic, it can be non-genetic. If it's genetic, it can be syndromic or non-syndromic. So it starts from taking the history, examining the child, what tests to be done. But in these sort of situations where there is treatment, there's cognitive, there's use of hearing aids, you always need to discuss with the family, would they like to do a prenatal? So it actually starts from there. And then we do the genetic test only if they are willing to do a prenatal. Pose the question to the family is that if you do a prenatal diagnosis and the fetus is affected, what would you like to do? Because sometimes they don't think of all this, and when actually the report is in front of them, they become very confused. What is the choice of investigations in a couple who are having recurrent abortion and recurrent child? So this, I'll read the question out. What is the choice of investigation in a couple who are having recurrent abortion and recurrent child with multiple anomalies? This looks like a chromosomal disorder. So I would like to first do the karyotype of the couple to look for a balanced translocation state. And if the child is there who have multiple anomalies, I would also like to do a karyotype or a chromosomal microarray of the child. The audio is not clear. I hope it is clear now. Okay. If the birth defect is diagnosed just before 20 weeks, should invasive prenatal tests still be advised if the family wants to carry forward with the pregnancy? Yes, that is a bit of a challenge because we know that all the tests take a little bit of time to come back, and it could be that the pregnancy is far advanced. At times, it does help to know what the cause of the malformation is. Say, supposing you've got a major malformation, say it's a diaphragmatic hernia, and your chromosomal microarray comes back as normal, and you know that there is no other associated malformation, the probability of, say, even a syndromic disorder becomes less. You can't exclude it because you cannot pick up every malformation antenatally. And then the family is prepared for surgery, would deliver in a tertiary care center where those facilities are available. Could that PCR process be explained in detail? What PCR? Are we talking about the QF PCR? So I think I've answered that question in detail. If both partners are positive for thalassemia minor, do we do a CDS? Yes. If both partners are positive for thalassemia minor, it means thalassemia minor is equivalent to being a carrier of beta thalassemia. Then there is a 25% chance that the fetus could be affected with thalassemia major, and the CDS can be done for that family. How effective is PGD in India, and are there specific centers you might recommend? So PGD is freely available in India, and there are many centers who are doing it. But remember, before you do a PGD, so this is definitive, say, for a diagnosis. So you have, say, thalassemia major, they've had 2-3 pregnancies where the fetus is always coming affected, and now they're fed up, and they want, you know, to do a pre-implantation genetic diagnosis and just put in the embryo without the thalassemia uh, major phenotype. So that is possible in India, but remember that even if you do a PGD, confirmatory testing has to be done in pregnancy, and that because the probability that the child is affected, the fetus is affected is small. We usually do an amnio at about 17, 18 weeks of pregnancy, where we get a good amount of DNA and we can check for the mutation in that. A previous child diagnosed with biotinidase deficiency, mutational study not done in the index case, now she's 6 weeks pregnant. No, we would not do genome sequencing in the parents. I understand that because it's biotinidase deficiency, I presume that the child is alive because it's a very simple disorder to treat. And you would first test the affected child for the change in the BTD gene and then check the fetus. You would not do a genome sequencing in the parents. If your diagnosis of biotinidase was confirmed by enzyme testing in the affected child, you would only sequence the BTD gene in the parents and then do a CDS. But if the child is alive, please test the child first because that's at half the cost. When you do the parents, you're doing 2 samples. If you're doing the child, you're doing 1 sample. And whatever mutation you get in the child, confirm that 1 mutation in the parents because they are carriers for this, and then do the CDS test. RH negative underwent MTP but not received NTP. How to proceed further? So I guess she is pregnant now if she's RH negative, and I presume that her husband is RH positive, because if he is also RH negative, there's no risk for the baby. But if he is RH positive, then you would test the indirect Coombs test of the lady to check whether that is negative or positive. And if that is positive, then you would follow the pregnancy carefully by doing the MCA, the peak systolic velocity in the middle cerebral artery from about 16, 17 weeks of pregnancy. There is an option of genotyping the father because he could be RH positive with the plus minus allele, the big D allele, in which case there is a chance that the baby could be RH negative, where there is no reason to follow up with serial MCA peak systolic velocities. If you could please explain in brief when to do NGS and when to go for microarray. Okay. So remember, next generation sequencing is looking at single gene. So they are for monogenic disorders. A microarray is for a chromosomal disorder. I think as of now, it is a bit of a challenge to use next generation sequencing in fetal life until whoever is interpreting the reports is very clear. Because you get certain variations, you don't know their consequence. So I would say for the time being, hold on to the random use of next generation sequencing in fetal life unless you are linked to a unit who understands how to interpret those results. Okay, next generation sequencing, you can sequence 6,000 genes and get variations you wouldn't understand what to do with. Now, an example is if you have a fetus with malformations, you would do a microarray first. Okay, but um, where you can use next generation sequencing is, say, if there is an increased nuchal translucency, you've excluded chromosomal disorders by a microarray. When you see that in your level 2 scan, there is some other clue which can suggest a rasopathy, because these are the guidelines. Either the nuchal fold is increased or there is some cardiac abnormality, then you could do the panel testing for those 13 or 14 genes that are associated with the Noonan syndrome-like rasopathy disorders. Are the results of fish and karyotype always concordant, or can there be a discrepancy? That's a wonderful question. And so remember, fish, like I showed you, looks at a specific point on the 5 chromosomes, 13, 18, 21, and the sex chromosome. Now, you could be having a Turner syndrome where the initial fish came as normal, or you could be having some other disorder where the probe did not hybridize well and it appeared to be normal or abnormal, and you could have a discrepant phenotype on the karyotype. This is an extremely rare situation. Remember that it is not a normal situation. It is a rare situation, but it can happen. It can happen. Could you please emphasize the importance of preserving index sample whenever possible? We often have no samples from the first proband child. Yes, that is also a very good point. So whenever you have, say, a pregnancy that is discontinued for multiple malformations, and I would be taking that in future talks, remember that you need to note down the malformations. There is no point in writing a baby was delivered with multiple congenital anomalies. It really makes no sense. You have to note down what were those congenital anomalies. You can keep either some part of the placenta, but I really don't like that because sometimes you just keep, we just kept the maternal decidua. So either you separate the chorionic villi from the fetal surface of the placenta, or what is better, you can take a large piece of the umbilical cord from the fetal side, and in that umbilical cord have the DNA stored. At that point in time, the families, when they give birth to a child who's not normal, really don't want to talk anything about testing because they feel they've lost their child and what is the reason to test. But later on, as they settle down, if you have the DNA of the baby, it always helps. Family history of a brother died due to extinct adrenal leukodystrophy, point to be included in preconception counseling. Yes, this is like any genetic disorder in the family. If there is X-linked adrenoleukodystrophy and we have the diagnosis confirmed by the mutation study, then we can test the fetus. We do know that we are allowed to check the sex of the fetus in these situations, but however, typically at 11 weeks of gestation, I think it's a little challenging, to say whether it's a male or a female. So it's always better to do the confirmatory testing again after the mutation identified. So that principle remains the same for all single gene disorders. In case of recurrent abortions, what exactly do we look for in the couple? We look for if one of the partners of the couple are a carrier of a balanced chromosomal translocation. Now, this is done by a karyotype. We do not do microarray to look for balanced translocations. Okay, so you have to do a karyotype. Nowadays, we get a lot of cases of IVF done abroad where PGD has been done. Should these patients undergo biochemical screening for trisomy 13, 18, 20? So It really depends. Have they done a screening for chromosomes, or have they done a screening for a single gene? Or have they done a diagnosis for a single gene disorder? So you need to understand what test has been done. Okay. Sometimes they do a microarray. If a microarray has been done, you do not need to do biochemical screening for 13, 18 days. But if they've done a PGD for a single gene disorder that was there in the family, like thalassemia or SME or a metabolic disorder, and they have not done a microarray or they have not done some test to look at the chromosomes, then you would need to do the screening. But remember that when you do a screening for IVF, you have to give in the IVF data, you have to give in the data of embryo transfer, etc. So I think I've answered all the questions. I don't see any more coming up on the screen. One more. Also, could you please emphasize on not revealing the carrier status of a female fetus for an X-linked disorder? Well, yes, you don't really do, because they know that they are females and they would discontinue pregnancies. So this is really not so much for the obstetricians as it is for the laboratories who are doing the test. So I think we conclude this session because we have completed our time. Thank you very much. It was a pleasure talking to everybody, and I hope it has been of some benefit to all those who've given their time to come and view this webinar. Thank you again.